Welcome everybody to the Injury Prevention Plus Seek QI program. We are in the 5th wave of the program. This is the learning session. Thank you to our program partner, ODH, the Violence and Injury Prevention Section, or VIPS. I have added a QR code here for you to scan and learn more information on their section. This is Wave 5's current program team. We have the privilege of working with Mike Gittleman from Cincinnati Children's Hospital Medical Center. Liz Lendrum is a new addition to our program team this year. She is also from Cincinnati Children's Hospital Medical Center. We have the pleasure of continuing to work with Zainab Al Abdali. She is our epidemiologist and data analyst this year. And then I am Brooke Powell. I am your program manager for the Injury Prevention Plus Seek program. I will be your main contact for anything program related. So if you run into any issues, have any questions, have questions for our experts, have data questions, I will be your conduit for contacting the team for anything program related. So welcome everybody. Our agenda today is hearing from Dr. Gittleman about social determinants of health and practical applications for counseling in the primary care setting. And then we will go over some high-level overview of program information. As you know, we will get into more detailed information regarding the program and program implementation on your kickoff calls. And then we'll go over some next steps. So if you can do so safely in the chat, please share your name, your practice, and your motivation for joining the SEEK program for this wave. And a little bit about what makes Wave 5 different from the previous 4 waves. Thank you for participating. We get a new group of providers enrolled for every wave of the program, which we learn something from the participating providers for every wave, and we are thankful for you. You know how important this work is to your patients and caregivers, and we appreciate that you are here. For this wave, we are offering a variety and your choice of tangible resources for your patients and caregivers. I'll leave it there, a little bit of teaser, and we will give you more information on what will be available to share on the kickoff calls. And we want to focus this wave on empowerment and encouragement. We want to empower you to have the new conversations with your caregivers. We will also empower you to maybe talk about topics that you haven't been comfortable with in the past, but we're going to arm you with talking points and then resources to share with your caregivers to make their homes as safe as possible. And then this way, we are encouraging caregivers to listen to you and learn from you. And with that, we will be collecting caregiver feedback. So we will get the insight into what the caregivers are hearing from you, engage what they learned from the screening process, and then their willingness to make a change based on the screening process and what they learned from you. So it should be interesting for Wave 5. And Mike, I have your slides.
Great. Well, thank you for everyone for joining. I get the pleasure of talking to you a little bit about a background of social determinants of health and injury counseling and some of the work we've done and the reasons why it's important. Brooke, can I advance or you have to advance?
I'm currently sharing, but if you would like to, I can stop sharing.
No, it's okay. I'll just say next slide. That's fine. Okay. I have nothing to disclose. This program's sponsored by the Ohio chapter of the AAP as well as the Ohio Department of Health. Next slide. So I always think it's worthwhile to start off with a case, and I think that cases hit home a little bit, especially for us in the clinical setting, because a lot of times you sit there and say, I hear about this stuff, but how is it really practical? So I work in the emergency room with Liz Lendrum at Cincinnati Children's Hospital, and this is a case of a newborn who presented to their primary care office at 2 weeks of life. It was their first visit. They were full term, no complications. And then they were lost to follow-up, and there was really no further visits, but there were several ED visits over the next couple of months. Next slide. Next thing we know, EMS presents to the house of a 3-month-old patient. Patient was found in mom's bed, pulseless, unresponsive. Upon arrival to the emergency department, they were in cardiac arrest. Attempted CPR, we had no return of spontaneous circulation, and they were pronounced in the emergency department. Next slide. And so when you look at this case, which is just horrific, and I know, Michael, you mentioned about safe sleep, which is, an important aspect, especially for these kids under 6 months of age. This family lived less than a mile from the children's hospital, right? They were unable to keep appointments because they had transportation challenges. They had more than one child and they couldn't get everyone together. They had no car. They had unpredictable work schedules. The parent felt that if she missed work, that she would be fired and she needed to work. They received no counseling about safe sleep at the 2-week-old visit, and the family had no funds to purchase a crib. So imagine if we were able to elicit this information early on, provide the family with resources to be able to help them with what their needs were. We could have prevented this whole activity from occurring and this unsenseless preventable death. Next slide. So what are social determinants of health? We hear this all the time. And the way I like to look at it is they're necessary resources for families: food, housing, economic, social relationships, transportation, education, and healthcare. And it's across populations. It determines the length and quality of the life a family has. So if you are lacking food, lacking housing, your length and quality of life are significantly less than others. Next slide. So what I want to do today is have you learn a little bit more about pediatric injuries and social determinants of health, understand how we try and incorporate it into well child visits, and then learn how we can counsel and use available resources. Next slide. So I don't know, Abraham Jacoby, as a longtime AAP member. So Abraham was the founder of AAP. He realized that the American Medical Association really did not cover everything that was needed in pediatrics. So he started really the AAP. And he said, it's not enough to work at the individual bedside in the hospital. In the near or dim future, the pediatrician is to sit in and control school boards, health departments, legislatures. So even Dr. Jacoby realized that, there is more to health than just well child care visits and immunizations. It's really the social aspects of health are incredibly important. And we need to find ways for pediatricians to get more involved to understand what the needs of their patients are. Next slide. So this is the family's perspective when, you're seeing them in the office. And Brooke, you can click through these. But, my window's broken. There are roaches. My landlord isn't responding. It takes about 4 hours to get to the pharmacy, 2 hours to walk there and 2 hours back. I just can't do it. I was in the hospital. I had no money, no food, no gas. And it was just horrible because I was breastfeeding and I'm basically eating nothing but cereal that I was been given by the doctor. So these are true social determinants of health that these families are facing. And so the last person, her child was in the hospital. She's breastfeeding and she can't eat. So you can imagine if she is having these problems, how's she going to care for her children and really be able to be effective, and how are children going to be successful later in life? So next slide. And again, Brooke, you can kind of scroll through these. So what I want us to start thinking about is we want to try and provide equitable care. Okay, so in the absence of avoidable difference among groups of people, we want to try and make it so the boxes match the needs. So if you take a look all the way on the right, you see there are different sized boxes because families have different needs to be able to look over the fence. If you want to click a couple more, Brooke. However, unfortunately, what do we usually provide? Equal care, all right? And so equal care is, if you look on the left picture, all the boxes are the same, and some kids can see over the fence and some can't. So equal care is what we all try and strive for because we want everyone to be treated equally. Unfortunately, our patient population isn't that. Our patient population has many different needs. We need to assess them and be able to give equitable care. And so what we really want to do is try and find a way, how do we get these boxes to meet? And then we can avoid some of these disparities. Want to click? So we want to start moving towards justice, which is equity, as opposed to equality. And how can we do that? Well, we need to first assess what are the problems so that we can make things equitable for each kid. Next slide. So are there really health inequities? There are. And here's just a few examples of them. So in education, African-American mothers with a high school education are 2.2 times more likely to have infant death in the first year of life. Lower socioeconomic families is associated with increased risk of many diseases like heart disease, arthritis. Access to resources. So lower income and racial ethnic minority communities are less likely to have access to grocery stores, fruits, and vegetables. And unfortunately, it used to be that the pediatrician lived and worked in the community. They were the eyes and the ears of the community. And it's just not that as much anymore. Pediatricians might live in a different community, but work in a specific community. They might not know everything that's happening and all the problems. And we need to be able to assess that to be able to help. Next slide. And you can scroll through these too. So what are some causes for lower health equity? Well, social environment. So social capital and cohesiveness, is one problem. So adverse childhood experiences. So in some environments, kids have worse experiences. And unfortunately today, and we're starting to see this, that children don't have as much resiliency. So they might have similar experiences as they had in the past, but we're really not affecting them with being resilient. There's discrimination in many communities. There are economic problems. So some families don't have the economic means, or they live in poverty, which affects food, which affects transportation and other things that they need. And then lastly is their physical environment. Sometimes indoors there's mold or roaches, or outdoors there's no playgrounds. There was a study that was done in Cincinnati, and we found that families in lower socioeconomic communities are closer to getting to McDonald's and fast food than they were to any kind of playground or outdoor activity. And so we don't have these in some of these communities where kids can be vibrant, play, and really be able to strive. Next slide. So what are some of these social determinants of health? So we mentioned some of them, but these are some of the ones that we address within our program, which is access to healthcare, access to resources like food, education, employment, environment, income or poverty, insurance coverage, housing, discrimination, segregation, and transportation. Next slide. So what we want to start doing is, one, we have to assess what are the needs of our families. How do you assess that? You have to ask. Many of us aren't even asking right now. That's one of the benefits of this program, is it enables us to ask the questions, to say, what are your needs? And then what's the next part is interventions. So by supplying resources to families to meet their needs, now we're actually providing equitable care. So it's not that everybody just says, here are resources and given a pamphlet. We're actually screening them, and we're providing tangible resources as well as tailored messaging to what their needs are to be able to have them be more effective. And many of these interventions can be started in a pediatric office. So things such as, can I provide telemedicine for my next visit? Can I provide resources in legal counseling? Can I get housing development? Can I show them how to get more involved with their community? These are things that we'll be able to do. And next time they could have a crib, for example, so that the child that was lost to follow-up didn't have to sleep with their family and have that fatal outcome that I presented at the beginning. Next slide. And you could scroll through these. But so what we want to do is assess the risk at the office visit and then match them to this risk to what the action plan is. So what if, for example, you don't have a job? Okay, well, where can I send someone to be able to get that? What is their needs? Is they don't have a job because they're not able to get there and drive to the interview? Do they not have a job because they don't know where to go? And then we have so many resources that are local and in the state that we could match families up so that when they're screening that there's a risk, that they now have a resource to be able to at least be able to get more information or some assistance. Next slide. In addition to the social determinants, we found that the number one cause of death in children by far is unintentional injuries. So if you take a look in this top right corner, this was presented at a National AAP conference last year. And if you take a look in this 2 years ago when the data was available, 59.3% of all deaths to children were the result of some sort of injury, either unintentional injury, suicide, or homicide. So they cause more deaths than all diseases combined. And those that are most affected by having an injury are those that have higher social determinants of health. So they don't have funding, they don't have resources, they don't have playgrounds to play at, and they are more likely to be injured. So that was one of the reasons why we merged these programs together, because if we're screening for social determinants of health, why aren't we also screening for injury, which is the #1 cause of death? And why aren't we trying to prevent that? Because our goal as pediatricians is we want to prevent morbidity and mortality of children. And if this is the greatest morbidity and mortality, how do we affect it? And so what we want to do is counsel families about injuries when we assess risk. Now, many might say, does it even work? Families don't seem to change their behavior. But I would tell you that the literature says otherwise. So first, if you do anything by screening and counseling, let's say you say to the family, you shouldn't sleep with the child. And the parent says, you know what? My mom told me that's what you're supposed to do. You're supposed to bond. And they are not ready for that change in behavior. Well, you did your job. You increased their knowledge. You gave them best practices, and then they made their own decisions. But by not even educating them, then they can't make those decisions. So besides increasing their knowledge, we have found that when you increase their knowledge and it's provided by someone like a physician, families actually change their behaviors. We've seen an increase in motor vehicle restraint use, smoke alarm use, infant safe sleep practices after counseling by their physician. And then when they change their behaviors, there is literature to show injuries can be reduced, which is our ultimate goal. Next slide. So we wanted to show you that we decided that that's the problem. We're not addressing social determinants of health. We're not addressing injury all that readily. How do we screen? And then how do we put this into the clinical setting? And that's why we're excited that you're going to be a part of our program to be able to really show some change in your practice. Next slide. So I'd say, boy, it's been a long time now, but we started with an injury prevention program, I would say close to 15 years ago. And what we did was we developed a screening tool for kids birth to 1 year of age. We basically said, #1 cause of injury, what do we do to affect that injury? And how do we really be able to affect families? So we put a QI program in. And what we found, what was really interesting, was the tool was easy to implement. I mean, if you actually have some type of standard processes within your practice, you can get these tools into practice within 1 to 2 months. It actually reduced the time of the physician counseling, because what we found is most families get maybe 4 or 5 things where they're deemed to be at risk. So then you can actually tailor your messaging to those 4 or 5 things. You don't have to counsel about 60 things. So it makes you more effective because you're counseling about what their needs are rather than just counseling about everything. And then when we followed families up at return visits, we found about 65% of families reported that they made at least one change in behavior after counseling. So we really showed that families will change their behavior based on the counseling that you'll be providing. Next slide. So the SEEK program really helped us with the social determinants of health. SEEK is Safe Environment for Every Kid. It's a program that was started in Baltimore, and really it screens for home social risks and social determinants of health. So it screens for like unemployment, low socioeconomic status. And then in the program, when they evaluated it, they showed that there was no additional provider time to implement. They had fewer child protective service reports, fewer instances of medical neglect, fewer children with delayed immunizations, and fewer instances of severe physical assault based on screening early and be able to assess and provide resources than waiting downstream. You know, they always say that prevention, you want to capture things upstream so that you can actually make a difference, because once they come downstream, it's much more difficult. And in regards to injuries and other problems, you can actually have some morbidity that can be acquainted to that. Next slide. So when we developed this program, we developed these tools for families to put, or for providers to put into practice for families. We use QI methodology, which really the QI methodology is, how do we do this every time? And as I said, we got this into practices within 1 to 2 months. And once we started screening, once you get it in, then you have to say, okay, how do I make sure I'm addressing their resources and needs? And then, as Brooke said, in this program, we're actually going to poll families and see what is their readiness for change after having the discussion. We've had 4 waves of this Injury Seek program since 2017. That's when we added Seek to our injury program. Ohio AAP members get 25 points MOC4 credit. And we also added additional topics to address. Next slide. So you might ask, well, what do we screen for? So with the Seek tool, we screen for employment, childcare, utilities, substance abuse, maternal depression, many social determinants of health. And then for injury, we screen for age-appropriate injuries. So between birth and 1 and 1 to 5, it's screening for the same things, but the questions might be a little different because a 3-year-old is different than a 6-month-old. So we would ask more about furniture falls and, in the toddler age, whereas we might not ask those same questions in the younger age group. And with this program, we'll provide you tools, talking points, and then community and national resources. Next slide. So with this quality improvement program, the things that we found to be really helpful is, 1, you need a core program team. A lot of pediatricians will come in and say, I think this is important work. I want to put it into practice. And you realize that you can't do this alone. You have office staff, you have nursing staff, you might have PAs or medical assistants, you might have nurse practitioners. Well, everybody needs to be on board, because if you say every day I'm just going to put it into my system, you're going to forget, you're not going to have some consistency. So you really need to make sure everyone's on board to be able to put it in so that you can actually do it every time and change the quality of the work that you're doing. We'll have kickoff calls such as this one right now, where you kind of learn about the why and kind of what the resources are. And then what's really nice is, the Ohio AAP staff is incredible. They will help you in any way possible. So you have questions of, I'm having a hard time getting this into my practice. Well, what can we do to help? We would even do site visits. We can even help you with, if you're having problems collecting your data or having families fill out the forms, we can problem solve and strategize with you. The other thing is we have monthly action period calls. So what's nice is you can say, I think I'm doing a really good job. And then you find out, well, I'm really not actually counseling when I should be on certain things. Like we found on some things that providers might feel uncomfortable addressing, let's say, safety in the home. Well, if they're having a hard time discussing this, then they're not going to have the counseling. So we have to do a better job of educating providers. And that's why at each of our monthly action period calls, we have about a 15-minute educational session on different areas and topics that we feel either we're seeing that is not being counseled, or either you say to us, hey, I'd like some more education on that so that we can provide it to you. We also ask for 3 plan, do, act cycles, which really a PDSA is, how do I get this form in every time? Okay, and so that might be 1 PDSA, and you trial different things to see how to make it work. Another PDSA might say, boy, I'm only counseling on half of the things. How do I counsel on more? So maybe it's the MA or the nurse, actually highlights and says, you need to counsel about these items. And so that's how the team comes in to make sure that you're most effective. Next slide. And then we're going to have a data collection. And I know everyone gets really nervous when they hear, oh, now I have to collect data. This is going to be a lot of work. Really isn't that much work. We ask for some baseline data. And the reason why data is so important is without the data, you're not going to be able to show change. And without being able to show change, then it's going to say, well, what am I really doing here? But it's really nice to say, when I started, I was counseling at maybe 40% of the time, and I got to 90% by the end. It really shows a practice, like how great they've done. And then you can celebrate as a team and say, look at all the work that we've done and how much we're doing better for our patients. So we usually ask you to collect some baseline data, which is randomly selected charts for two age groups, the birth to 1 and the 13-month to 5 years. It's pretty easy. You're just going to submit it into SurveyMonkey. And then during the action period, you're going to collect data from families. We're going to give you an iPad to really be able to collect it. And it should be pretty mainstreamed and easy to use. And then we are very fortunate to have Zainab as part of our team, where she's going to analyze the data. She'll give you individually practice information to see how your practice is doing. And then she'll give you collaborative information to see how we're doing it as a whole group. Next slide. So this is just some results that we found in waves 1 and 2, just to kind of get you excited. So in baseline for the birth to 1 year and 13-month to 5 year, they're very similar, but we found that only 31% of the time were injury and seek topics addressed at baseline for the younger kids. It was 24% for the older children. And the most common items that were missed were sleeping on your back, car seat safety. And in the older kids, it was they can't care for their child and maternal depression. When we actually looked during the action period, as I said, most families only got 4 or 5 areas where they needed to have them addressed. And the most common were families didn't know or understand about CPR, and they never had a car seat checked. They just put it in as they thought, and many of the times they were not appropriate or fit appropriately. And so we would give you resources for the families and say, hey, look, it looks like you might need your car seat checked. Here's a good place in your county or community that you can get it done for free. And then what we found was by the end of the collaborative, they had families were counseled more than 80% of the time on areas where they were at risk. And it was an increase by about 50 to 60% from baseline. So what we showed was the counseling wasn't being done. You put the tool into place. We had counseling. When problems were there, they were addressed more than 80% of the time. So we made significant difference just in this short little collaborative in how you were caring for families. Next slide. And the other thing that was kind of interesting that we found was more families had unintentional injury risk than they had social determinants of health risk. Now, we haven't gone back and taken a look to see, is that because the communities that we were in, is that because maybe some families aren't feeling comfortable addressing some of these social risks? That's one of the reasons why we wanted to get some family input at the end, which was how likely are they going to change their behaviors? Is there anything else they want to tell us? And so hopefully we can get a little bit more into these social risks. But you can see that, almost 20% of the time, unintentional injury risks were getting observed, and we need to be able to address them. Next slide. So this is our last wave that we just completed. And again, we found very similar results, was that injury topics were addressed at an average of 83%. Social determinants of risks were addressed only at 44% at baseline. So the baseline were a lot higher for wave 4. And then on completed tools, we found that they were addressed more than 99% of the time on both. And the greatest change was in home safety, where we started at only 55% at baseline, got up to 94% being addressed just by using the tools that we were providing. Next slide. So in wave 4, the most common questions that were answered and showed minimal risk. So what we found was, would you like help finding a job? Is your child difficult to care for? Need to slap or hit your child? Used an illegal drug? 4 more drinks in one day? Sleep in a place that's not like a crib? These are the ones that were most commonly answered appropriately. And similarly, in the older age group, paying your utilities, worrying about food, again, about hurting your child or drug use, And then restraining your child in a car, leaving your child alone, and access to medications and firearms were areas that were not missed commonly. Next slide. The areas that we were finding significant risk, you could see the social determinants of health answers were not as high. But again, I think we have to look to see what communities that we were in. We did find that in the older age group, a lot of parents felt that they were under significant stress. And so giving them some resources or help with that could be very beneficial. We did find there was a lot of injury risks, though. So, for example, families didn't know first aid or CPR. Families weren't having their car seats checked. Families weren't having their furniture secured. And, as you know, working in the ER, we see a lot of furniture injuries where kids will fall out of couches, fall from dressers, those kind of things, as well as there was a lot of small objects that were available to kids. So they were having unintentional choking hazards, which were also a risk. Next slide. So as Brooke said, in this next wave, what we're excited about is to get some caregiver feedback. So, how ready are they for change? What action steps are they going to take? And then we want to start comparing our responses to some national averages. So as Michael said, he's been a part of some other Ohio AAP programs. We also run a smoking cessation program. And what was great was we found that our smoking risk in families was very comparable to national averages. However, after we put the quality improvement program into play, we found that the ability to get families to quit smoking or reduce their smoking was far greater than other programs nationally. So we're excited that we're going to start looking at that as well in this program. Next slide. So I just want to spend the next few minutes just talking about behavior change theory and maybe some next steps. So you want to go to the next slide? So unfortunately, families go to the path of least resistance. I mean, we all do. We sit there and say, you know what? I'd like to change the smoke alarm battery, and I really need to do it. And I usually do it when, we change the time clocks. Well, we've changed the time clocks. I was away that week. So then the next day I go, I really want to do it. And you forget. Families want to make this change, but sometimes we have a hard time getting to what their needs are. So as I said before, the first part of our job is education. So when we screen and find there's a risk, we really need to get at how do we educate them to change their behaviors. And if questions are counseling, then we need to educate them to really try and see what is the likelihood we can get them to change. And then if they've had misinformation, then how do we make sure that that is addressed? I saw this thing, I don't know if any of you went to National AAP last week, and there was a lecture and they said the greatest risk on medicine in our next 10 years, our next decade, is misinformation. And so us being able to supply families with appropriate information is really going to be helpful. Next slide. So when you're looking at it, I'm going to talk about two behavioral change counseling models. So the first one is the health belief model. So when you find someone screens at risk, right, the risk is because the family has this perception of, you know what, I don't have to worry about it. They might say, you know what, I live around the corner from the supermarket. It's a block, 2 blocks. I don't have to put my seatbelt on. The risk, I haven't been in a collision in 20 years. I should be fine. Then they sit there and say, well, what's the cost benefit analysis? I have to spend $60 on a car seat. I'm only in a car maybe half the time. It's not worth it for me to get one. And so that's how they look at their behavior. Our job is to, one, make sure they understand that risk perception is real. And by providing the resources in this program, we can hopefully address that cost benefit analysis. Next slide. But one of the key changes to help them change their behavior is really providing self-efficacy. So sometimes there could be a cue to action. You talk to the family, and as I said, you have 4 or 5 items where you're addressing them, and the family says, you know what, I haven't ever had my car seat checked. So you could sit there and say, I saw on the news on my way to work, there was a horrible collision the other night on 71, and family didn't have their car seat restrained. And they say, oh, now you're getting at that point of the perception. Perception's real. But one of the key factors is self-efficacy. So asking that question of how likely are you going to make this change? And if so, what can I do? They might say, you know what? My problem is I don't know where to get the car seat. Okay, I can help you with that. Maybe it's I don't have the money for the car seat. So digging deeper and finding what the problem is going to make them more successful. Sometimes it's not just, hey, I saw that you need to get your car seat checked. All right, here's a phone number. Maybe it's, hey, look, before you leave, we can make that phone call for you and set up that appointment. Maybe it's, I'm going to call you in a week and find out how you're doing. Those kind of things institute change far greater. Next slide. And you could scroll through these too, Brooke. The other model is the trans-theoretical model, which is understanding where the family is with change will help you decide what kind of discussion I'm going to have with them. So, for example, you say to them, you know what, your child really needs to be in their own crib. And they say, you know what, totally not interested. Okay, so maybe then you say, well, let's raise a little doubt. Maybe they say, well, I might start soon. Well, so then you have a different discussion where they say, I recently started. Great. How can I make this and help you more? Next slide. So this gets into, so maybe our discussions are, if they're not ready, we just say, raise some doubt and say, you know what? I wanted to make you aware of this, and I really want you to try and do what's, appropriate for your child based on the literature, or I'm here to answer more questions. Maybe they're unsure, and so you can explore change with them. And if they're ready, develop an action plan. And if you address a couple of these harder things to change, such as getting your car seat checked, as we showed, learning CPR and caring for your child in an emergent situation, giving the number for the Poison Control Center, these action plans can really make a significant difference. Next slide. So what I wanted to do in this beginning is, one, highlight why this program is really important. These social determinants of health and injury risks are real, and we assess them, and we notice that many of our families have these problems, and we as providers don't know how to address them. So this program will help you address them and help you be able to put it into practice. Not only that, you have the resources of the Ohio AAP behind you. So Brooke and Liz and Zainab and Haley, and myself, we are here to answer questions whenever you need it, as well as we have resources within your communities and within the state to be able to give to families. And then lastly, helping you be able to give that effective counseling when needed and what's going to work the best. We are here for you. The last thing I'll say is the thing that's exciting is sustainability. We found that many practices, they might not use our entire tool, but they embed a lot of them into their Epic system or into other systems. So they're continuing to use them even after our short program is over. Next slide. I can answer questions at the end and ask Brooke to go forward, or I can answer them now. It's up to you guys.
Yeah, feel free to unmute or put something in the chat.
It ends fine with me.
Okay, Dr. Gittleman, thank you. Okay, to go over a little bit more about what Mike touched on, I want to give you some program information, kind of an overview of what is expected. So to revisit the breakdown of topics, these topics will be grouped in this way for data collection and will be shared with you when we hop on the action period calls and do the data review. We will be presenting the data of your screening tool data collection within these topics. So car seat safety, safe sleep. Under home safety is firearm safety, first aid, poison control, smoke and carbon monoxide alarms, and smoking in the home. I just also want to make a note that all of these subtopics are representative of one question on the screening tool. Family needs takes into account alcohol and substance abuse, parenting skills, domestic violence, maternal depression, parental stress, Social needs includes childcare resources, food insecurity, job resources, and housing resources. So on the left is a screenshot of what the paper version of the screening tool looks like. This is the hybrid tool that Mike talked about. So we have social determinants of health questions and injury questions combined into a hybrid tool. Again, this is what the paper copy would look like. You'll be sent some of these just in case your iPad isn't working that day or your patients need a paper copy. But primarily, this tool will be completed online via the use of the iPads. And the screening tool has 2 different versions, one for birth to 12 months and one for 13 months to 5 years. The screening tool questions identify areas of our potential risk regarding social determinants of health, intentional injury, and unintentional injury. This is what your patients and caregivers will be greeted with when they have the iPad in front of them. So you will get information on the login process and what would bring them to the online screening tool. Again, this would be conducted via iPad. They will be greeted with this message when they start the process. And so next steps for the program. If you could, please schedule with me your kickoff call in November. This will take into account teaching you about program implementation, screening tool tech for the iPads, and then the data collection training, what that will look like, including baseline. We have a pre-work survey that is active on SurveyMonkey. The link is right there, and also is the QR code. Some of you have completed this already, and I appreciate it. We will eventually go over those results and kind of use it as a catalyst to see what's currently going on in your practice and ask you questions going forward. Baseline data collection, like Dr. Gittleman said, we will be collecting baseline via SurveyMonkey. We hope to get that in by the end of November. More information will be shared with you on the kickoff call. So November is a busy one, but once everyone is kicked off, we can start the action period data collection. And we waited till the end for questions. If you think of something, please bring it to your kickoff in November, but I'm also available all the time via email with anything that comes up. So any questions?
I just had one regarding the equity or equality and kind of equal treatment slide. It looked like the Pittsburgh Pirates were selected for the team in the baseball. Whose choosing was that, given that we've got the Reds and the Guardians in Ohio?
Somebody gave me that slide, and it was too much of a pain to try and change the baseball
Fair.
players, but that's a good point.
Good observation. I guess we need to keep that current. Okay. If there are no questions, I look forward to talking to each of you and get this program started. Good things will be coming to you, and talk to you soon. Thank you so much.
Thanks, guys.
Have a good week. Bye.
Thanks for joining.